Are you a healthcare professional working with breastfeeding infants? Wish you knew more about assessing and treating tongue ties? Earn continuing education credits and transform your practice with the Professional's Guide to Tongue Tie in the Breastfeeding Infant. It's perfect for any practitioner who works with infants and their mothers, especially those working through feeding challenges. Learn to identify who needs treatment, build a qualified care team, and provide holistic care options. Discover the ins and outs of frentomy, including procedure preparation and best aftercare practices. By the end, you'll be confidently supporting breastfeeding families armed with the latest protocols and be part of an interdisciplinary community of experts just like you. Tongue ties are nothing new, but the right way to assess and treat them is. Ready to make a real difference? Join now and become a tongue tie expert. Sign up today at tonguetieexperts.net/professional and become the evidence-based resource that your community needs. To show my gratitude, I'm offering you a special discount as a podcast listener. Use code PODCAST40 to save 40% off today. You're listening to the Tongue Tie Experts podcast, a weekly program providing information and support for those families impacted by tongue and lip tie and the professionals caring for them. I'm Lisa Paladino, a midwife and a lactation consultant with over 30 years of experience. If you are a parent looking for answers or a professional who is curious to learn more than what you learned in school on this topic, welcome. This podcast is for you. A gentle disclaimer. Please do not consider anything discussed on this podcast by myself or any guest of the podcast to be medical advice. The information is provided for educational purposes only and does not take the place of your own medical or lactation provider. Thank you. Welcome, everyone, to this episode of Tongue Tie Experts. This is a Meet the Team episode. I'm Lisa Paladino, and I am honored today to have Dr. Scott Siegel as my special guest. Welcome, Scott.
Thank you, Lisa.
It is such a pleasure to have you here. I know you very well because we've been collaborating for quite a few years now. But if you wouldn't mind and take a moment and tell the listeners a little bit about yourself.
All right. Well, first off, thanks again for having me on here. It's always an honor and humbling. And it's a great service that you're doing. My name's Scott Siegel. I am, by profession, I'm an oral and maxillofacial surgeon. And what that means in my instance, I'm both a dentist and a physician, what we call a DDS and an MD. And I'd say the primary thrust of my practice that has kind of evolved over the years is taking care of tethered oral tissues from infants up through adults. But a big thrust of my practice happens to deal with infants with feeding difficulties, and that could be breastfeeding primarily, or it could be bottle feeding as well. But
can I just interrupt you because are there many people that are both a doctor and a dentist?
No, there's in my specialty, there's a growing number of oral and maxillofacial surgeons that have both degrees or both training in both. But it is kind of interesting and kind of nice for me because I get to have feet in both camps of the medical field and the dental field. And it's helped me, in forging relationships with both physicians and the dental area as well. And I think, just my knowledge base has been pretty broad that way as well.
Yeah. Do you mind if I ask how that happened?
Yeah, I mean, my history, which is always kind of fun and cool to talk about these things, and when you're talking about how we all evolved and got into these areas, but My father was a dentist, so I'm actually third generation dentist. His father was a dentist.
See, I learned something new about you every day. I didn't know that.
And when I was actually in junior year of high school, I spent the summer in his office and picked up a journal, and it had some articles about a story about a child who actually shot his face off with a shotgun, kind of gruesome, but about these doctors who were both dentists and physicians who restored and reconstructed his face. And at that point, I was like, that's what I wanted to do. And that kind of set me on the path of thinking I just wanted to, reconstruct faces and do all of these things. And that kind of led me, to going to dental school, going to medical school, and then my residency training program, which was in maxillofacial surgery, encompassed general surgery training. And it was actually in my general surgery training and in my medical school years that I got kind of roped into the tongue tie.
Yeah. So it happened because of where you were and who was with you, right?
Yeah. I was fortunate enough at the time when I was in med school and doing my surgery rotations. I actually did rotations in pediatric surgery. And there was a professor there at the time. Her name was Elizabeth or Betty Carrillos. And for those of you who don't know, she happens to be one of the pioneers in tongue tie, procedures, and actually came up with a classification system for infants, dealing with tongue ties, called the Carrillos classification system. When I went into private practice after these years of, working with her, and I was a resident with her, and I happened to go into private practice across the street from her office. And the rest was pretty much history. But my history with the ties and the babies and all of that started at that point. And that was in the year 2000, I guess. When I went into
it seems like a long time ago, but when you're talking about a field of medicine, it's not a long time.
It's a pretty short period of time. And at that time, she was doing a lot of work with lactation consultants and, helping them, get babies back on breast that were having difficulties. And we were working together. We would share patients, and she was, part of my department in the hospital. And she had come over. Actually, she was a patient of ours, and she was starting to talk to me about, she knew I was using lasers, and I was doing a lot of facial plastic surgery and cosmetic surgery with carbon dioxide lasers at the time. And she started asking me if I would, treat some of the babies with her with lasers. Because
so you were already comfortable with using a laser.
Yeah.
And she realized that you could move that application to what she was doing, right?
Correct.
She wasn't using laser.
She wasn't using lasers, but it was being done around the same time by Dr. Kotlow, in Albany. So he was doing it at that time. She was turning me onto his work, and we all started kind of collaborating together and learning from each other. And, she would show me how she was doing these releases with a scissor, and she was basically kind of guiding me as a mentor with the laser. And it really kind of took off. At that time, she was also starting to conduct research with Catherine Watson Jenna, very well.
Who's also, everybody who knows anything about tongue tie knows Kathy Watson Jenna. She's like our hero, in the field.
So I was introduced to her at the time and kind of learning from all of these giants in the field, and not realizing, they were giants in the field at the time, but just friends. And
not realizing you were becoming a giant in the field. No, not to make your head swell, but you really, because the kids today, the parents today know of you the way we knew of them back then. So, you built yourself up quite a bit.
Yeah. And that just kind of happens over time. Almost, I look at it, it's just confluence, coincidence, accidental things, and then loving what you do. And it just changed my whole life. So it started to build at that time, and getting involved, with the lactation community and realizing the need. And when, Dr. Carrillos was starting to get towards the end of her career, she was like, listen, I want to hand over my practice to you, basically kind of hand the torch over. And she's like, you have, we felt that the surgeries trying to understand what we were doing was pretty straightforward, but there were a lot of nuances. And we were noticing that a lot of these babies were either being misdiagnosed, not diagnosed, and procedures being done incorrectly. And we still battle with that daily.
Absolutely.
So she introduced me to people worldwide who were in the field. She introduced me to a lot of, people in medicine and dentistry, and was able to kind of help, put me where I am today. I always have to go back to her.
Right.
And actually Kathy as well, because the other lactation consultants that I met 20 years ago and whatever.
Right. So do you think that the evolution of the growth of this field happened simultaneously in different places, and then you guys came together? Because that's how it feels to me.
I think everybody was kind of doing these things in different parts in their own little areas. And I think the biggest thing was like, we're all seeing the same things, but not communicating with each other.
Right.
And our experiences.
Right.
And at that time, they kind of formed what we call the IATP, which was the affiliation of tongue-tied professionals. So they can actually, converse and talk about the experience.
Yeah. I often talk about, I wasn't in the early conferences, but I went to the one in Montreal. And I walked in there, and it was the first time I felt like, I was like, wow, I found my people.
Yeah.
It was so collaborative. It was the only conference I'd ever been at that wasn't just one type of provider. Because, you go to dental conferences, I go to RN conferences or lactation conferences or midwife conferences, but they never overlap, right? And this was all the people that I just mentioned, plus body workers and massage therapists and people that take care of mental health of mothers and babies, and just everybody coming together, doctors, dentists, osteopaths, coming together and respecting each other equally. Like it wasn't like in other places, it's like, well, she's just a midwife, she's just a lactation consultant.
Exactly.
In this field, it has never felt like that to me. And I think that's part of what drew me in.
Yeah, 100%. I felt home, because even when at that time, I was in a group practice with like 5 other docs, and I was kind of even ostracized in my own practice because of that. They looked at me like, what are you doing? It's like, you can't have these moms breastfeeding in the,
in the dentist's office.
Yeah, it's like this thing, but, it was like, I really care about these kids. And my wife at the time was breastfeeding my first daughter, and you have all these connections and personal stories that become involved. And if you don't have an ego, or you can actually listen to people and let them guide you, it's how I've learned the most of everything. It's from all of my colleagues like yourself and all of the other people in the feeding community, speech community, that the functional therapy community, as well as the mental health. I mean, you learn from each other, and that's
and it's one of the things that has inspired me. I teach a course for professionals, and in my course, it's not limited to lactation consultants. It's open to anyone, and anyone who takes care of moms and babies in any capacity, because as we know, many babies or moms and babies never even get to a lactation consultant. They don't even know to go to a lactation consultant. There's not enough of us, and there's not enough of us who are trained in proper assessment. So these babies are just falling through the cracks, and social media can, it can kill you, but it can either inspire you or make you really sad. On my Instagram, I have a post that I put up every once in a while asking for stories of missed tongue tie, because I want to know what's going on. And it's just really pathetic when I hear, these babies that are either getting missed or being told that it doesn't matter, or they have a tongue tie, but it's not affecting breastfeeding. But meantime, breastfeeding isn't going well and nobody's giving them an answer anyway. So I really feel that every healthcare provider that has an encounter with either a pregnant or breastfeeding family needs to understand this.
Right.
Not necessarily diagnose it, but at least know their role in being able to assess is this a possibility, and sending them to where they have to go.
Yeah,
Right.
I couldn't agree any 100%, 1,000%, because it's, we talk about just either knowing when to refer. You don't have to make the diagnosis, but what is it? Jim Murphy, the pediatrician, IBCLC, very famous tongue-tied doc as well, who gave that, I think, at that Montreal meeting, talked about failure to diagnose.
Right.
How, if you're not able to make a diagnosis, at least put a couple of things together and know when to refer it out.
Exactly.
May know maybe
Yeah.
something more, and not just say you're fine, the baby's gaining weight, you're okay.
Right.
Just stick a
I
bottle.
like to paraphrase what he said, and said, if you don't know how to assess for tongue tie, please don't say there isn't one.
Correct.
Because,
exactly.
Yeah.
So,
yeah. Jim Murphy is great.
And what was this? I didn't comment, but I saw the post. I think it was by Bobby Gahary about, gaslighting moms and stuff like that.
Yes.
It's a big problem. And I don't know how many moms today who felt that way.
Right.
That the pediatrician or the people in the hospital were saying they're fine, everything's fine. And mom knows in her gut something's wrong.
Yeah.
With a latch or whatnot. So
Yeah.
there's a lot of
we're not trusting parents' instincts.
Right.
We're taking the instincts out of parenting, that's the scariest.
Biology, it's,
right.
It's human evolution and biology.
Right. And I mean, to me, it's common sense that something has to be causing the problem.
Right.
Right. So if breastfeeding is not working, we have to get to the root of why it's not working, instead of just saying, well, just give a bottle. Because as we know, sometimes just giving a bottle doesn't matter, because a lot of babies with these oral restrictions can't even take a bottle.
Correct.
So interesting. And I keep popping in with my grandson's story. He did really well breastfeeding, but he was causing his mom pain, and a couple of other things were going on, and he was obviously tied. He can't take a bottle because he can't suck on a finger. Mm-hmm. So he's got something going on with the oral motor thing in his mouth.
Right.
So if he wasn't breastfed, we'd be having a problem right now. And if my daughter didn't have a copious milk supply. So there's all kinds of presentations to this.
Right.
That are complex, that need proper assessment by people who understand how to assess, and mothers not being dismissed, because always, yeah. And then, I want to get into a little bit about what the actual procedure is, and we'll talk about that. But I just want to touch on the idea of, we hear the term preferred provider, which I don't really love that term.
Yeah.
But it's so important for families to understand how to know that the person that they're trusting their baby to for the procedure knows what they're doing. And you can do this by doing a search on social media. You can do this by, I have a download that I'll include here about questions to ask a provider before you let them, even before you make an appointment with them. And some of those things are making sure that they understand that they work with a team. Because if a provider doesn't have a team, you don't work in a vacuum. No. We're always communicating back and forth. And talk about the other people on your team.
Yeah.
Like, what other kind of providers?
We're all little pieces of a puzzle here.
Mm-hmm.
And I know you've given the lectures as, the IBCLC as a team leader and whatnot. Yeah, so my what I term my therapists, oral functional therapists, whether it's lactation, feeding therapy or whatnot, I really do feel that they're the leader of our team, because they really assess the function. And, we're treating symptoms and function, not just an appearance of something.
Mm-hmm.
And, so the members of the team, primarily is going to be a lactation consultant, or, some other oral functional therapist, or potentially a body worker,
mm-hmm.
and we talk about that as a broad category.
Right.
We find, so many of these babies are compensating when they're feeding. So they may be using their whole body, or they may have connections in the mouth, these ties can be connected with, with what we call fascia to other.
Right.
Things.
I was just going to say the tie is the fascia, right? So like in my grandson's instance, he has a subluxation on one side of his neck because of the position he was in. And he holds himself in that same position still at a month old. So we're doing we're doing occupational therapy and chiropractic and infant massage and oral exercises, all to get him to get back to midline. And we know that as he's getting back there, he's doing better. He's nursing better, and his tongue is getting stronger. So tell us about what frenotomy or frenectomy is. It's called both things, right?
Right. So yeah, the difference in the terms sometimes gets confusing. You have frenotomy, frenectomy, and frenuloplasty as categories of terms. When we talk about frenotomy itself, a frenotomy, or when you talk about otomy, it's just basically making a little cut in something, and it opens it up.
Mm-hmm.
So in simple terms, if you're using a laser or a scissor to make a frenotomy, say under the tongue, you're basically making a nick in the fascia, or what we call the mucosa, or the skin underneath the tongue, and you're opening it up. When you talk about a frenectomy, you're removing that whole frenulum, or that little attachment, as we call it. A frenuloplasty is when we start to get a little bit more involved, and maybe start to even do a little more intricate dissections to make that area longer, or wider, or go deeper. So there's different terms. Right. For the most part, when we're dealing with the infants and the babies, we try to do these more simple procedures called the frenotomy. And sometimes we can just do that. You can release these little areas, you make a little nick, and I use the laser to do this, and it's been my preferred instrument. You can use scissors if you're proficient. My mentor was a scissor provider. I've used scissors in the past. I just prefer laser because it works well for me at this point. And the advantages for me is I get a lot less bleeding and more control, and I can see a little bit more of what I'm releasing.
Yeah, I agree. I mean, post-operatively, when I see the result of either a scissor or a laser release in general, the laser release is more complete, and it's less of an angry looking wound, and it heals nicely.
And again, that depends on your provider and their experience.
Right. Exactly.
But so that's kind of the broad categories. And a frenotomy tends to be the most simple of the procedures to do, and it works very nicely in the newborns and babies that we treat.
Mm-hmm. And there's some on older kids sometimes, or adults. Sometimes you do the frenuloplasty where you're actually doing sutures and making sure things are in the right place.
Yeah. Sometimes we do that on, I've had babies where I've done it too. Sometimes I've had babies where they've been scarred down. I've had a couple where you've had to take to the operating room and put them under, and that's very, very rare. I've had to do that. But yeah, we kind of, you have to know the indications for each of those procedures.
Now, when you say scarred down, that means they had a previous release that wasn't done properly.
Right. Exactly. Okay. So in my practice, I tend to see a lot of complex cases that were treated by other providers, or had multiple revisions and other issues going on. So, there's no one size fits all with any of this. Right. And I would, term, these little kiddos are snowflakes. Each one is different, and each one requires a different team approach and having that functional assessment.
Absolutely. And we have had, we've had patients very recently who haven't gone to the right provider. And I hate to say it that way, but there are some doctors who aren't as educated in the techniques. And so you want to be really, really, really careful. Do your homework before you pick a provider. Don't pick a provider just based on cost or even location. I mean, I know a lot of people travel pretty far to see people like you, people like Dr. Kotlow. There are other providers in our area that are very good. But, when I'm asked by parents why I recommend who I recommend, and not just as a dentist, but for other healthcare providers as well, I always say, I always want to send somebody to the person who is the expert in it, not someone that says, oh yeah, I can do that. And you certainly don't want to talk somebody into it. Right. So I had a family recently whose baby, the doctor, I believe they took the baby to an ENT, and the ENT said, I don't think there's a tongue tie, but if you want, I can release it. So I said, and they ran out of that office. Thank goodness they were smart enough to say, because if he doesn't know what a tongue tie is,
right.
I'm sure he's a good ENT in every other aspect, but if he doesn't know what tongue tie is, if that's not his expertise, if he hasn't had specialized training to recognize what he has to do under that little infant's tongue, then that can be a disaster. And we have seen some disasters, unfortunately.
Right. Exactly.
Yeah. I had a question the other night, and it made me think a little bit, because we're still shifting what we do and what our protocols are. So somebody asked me about post-op care, and we have evolved our post-op care a lot in the last 5 years even. So about wound healing, and can you tell us the latest, what are the latest recommendations for what to do after?
Yeah, I mean, that's evolving. My aftercare just evolved even this week. We're changing things up, and it's mostly,
that's why I ask you.
the feedback. I changed my protocols. We try to do it as much as science-based as we can. There is an art to it, and with any of this, but there's also a lot of feedback, and I really depend on the feedback from you guys. From what are you seeing? What are you seeing in reattachment rates, or what you're dealing with? And so we've kind of evolved even this past week. Based on feedback, we're trying to do more simple stretches and just work on the quality of opening up the wound versus the number of stretches, trying not to touch the wound bed, massages,
which is new, because we used to
massage everything. And, maybe we're closing more scar tissue by doing that.
I mean, better, you do better, right? I mean, we're doing the best we can. I don't think we've caused harm to babies, but as we get more experience and we share results, we evolve. So somebody was asking about research, and I said, honestly, I think that they said, is it research or anecdotal? And I don't think it's either. I don't think it's anecdotal. I think it's experiential.
Yeah, exactly.
And
one of the difficult things we have in this field is providing the research or the levels of research that many people are looking for. So when you do that, there's no studies on this. There's no research on this. These are very difficult things to actually study and give, when you talk to pediatricians or other docs or other people in the healthcare field, they're looking for these studies that are what we call, randomized, controlled, double-blinded with huge numbers of subjects. And it's not, for some of it, it's not even ethical to do this with this population, because you can't group them into controlled and non-controlled.
You can't not treat a baby who needs treatment, right?
And then there's variables that come into play. And it's when you're talking about wound healing, you're talking about things, there's so many different variables. A lot of it is experience-based at this point, and what has been becoming best practices and best results for us globally. And it's not just, me talking to you it's all of us combined worldwide. And that's why we have international conferences. That's why we have our professional groups, and we're all talking about what are we noticing, what are we seeing with these things.
Exactly. I agree. And I think it's important for our listeners to know that the best levels of evidence it's almost impossible to get randomized control studies on some things. But if you see, usually what we see happens before you can prove it in research. Right. So that's the state that we're at right now.
Right.
I think the first do no harm is more important when we're thinking in this topic about not missing, not mistreating, not doing unnecessary procedures.
Yeah.
So I say all the time, just because there's a tongue tie, that doesn't mean the tongue tie is what's causing the breastfeeding problem.
Right.
Right. There could be all kinds of things causing a breastfeeding problem. From the simple thing of not holding a baby correctly. I mean, that's why a lactation consultant is very important. I see parents that are doing everything right and they're still struggling. But then I see parents who have no clue, have never seen anybody breastfeed before, and they're scheduling their babies, or they're treating their baby like a bottle-fed baby when they're trying to breastfeed. They're not holding the baby close enough, and just a couple of simple tweaks. And they're like, oh yeah, that's it. And the baby opens their mouth better, and everything, and nipples start to heal, and everything is good.
Right.
So there's that. So do you feel like how am I going to say this? What do you think the next steps should be in this field? Like where do you see this going as far as,
that's
what we need to know, what we need to do, how we need to train people?
Exactly. I think, education and training are really key, because, even you can't have, a blanket law saying that you need to screen these babies before they leave the hospital, because, how you have to even think about who is screening them in the hospital. How do you, come about this? So there's a lot of complex, pieces of the puzzle here, and no one right answer. We look at Brazil sometimes as a model, because they have it actually a mandated law that the babies cannot leave the hospital until they are screened. And they do have a classification system that they use there to look at structure and function. We don't have that in the United States at this point.
I've also heard that I've heard from people in Brazil that there's still people falling through the cracks.
Yeah, it happens.
Or not getting treated well. And when I say not getting treated well, I mean like not getting the proper treatment for their case.
And that's it's like they don't get the proper treatment. It's very confusing. One of the issues that we have at this point is the awareness has gone way up, and it's actually become, somewhat of a moneymaker for some practitioners as well. And there's people just, taking a weekend course and thinking that they can just automatically start doing it and get great results. I mean, there's nothing wrong with starting to do these things, but you need to have a team, and you need to, maybe be mentored. You maybe need more training before just unleashing it and doing it, because you start to see results sometimes, plummet a little bit. And there's this, back and forth between the medical community and what we do, saying that, there's been an 800% increase in these procedures that we see nationwide. And they look at that and start to say they're just doing it to make money.
Right.
And it gives us a bad name. And then you do see some results that are not great. So when you're talking about best practices and where do you see this moving forward, there's a few things I think to think about. Education and training are key, and integrating it into dental school training or medical school, education, residency programs. So you have to start where they're, coming out.
Right. I have to include in my questions to you a discussion about reflux because of your aerophagia articles and what you know about that, because there are quite a few lactation professionals that when I speak to them, they've never heard that reflux and tongue tie are associated with each other. So maybe we should talk a little bit about that.
Yeah, I mean, it's interesting. It's a phenomenon that we see, and again, it's experience based, and it's tough to prove scientifically, but we see it. Over the years of doing these releases, whether it's a tongue tie or tongue and lip tie, a lot of these babies, their symptoms of reflux started settling down pretty quickly. Within the time frame, what we call contemporaneous, within that time frame of the surgical procedure. And so many of these babies are on antacid medications or acid, blockers that can actually have serious side effects. And we found that you see it kind of worldwide as one of the knee-jerk responses or reflexes for GI docs or pediatricians. If a mom says my baby has reflux or seems to have reflux symptoms, it's just to automatically put them on the medication.
Right. Without looking for the cause of it.
Without looking, there could be just, there's different classifications of reflux, gastroesophageal reflux, or infantile reflux, which could happen when you don't have the, mature sphincters or those little, openings from the stomach up to the, esophagus into the mouth, and they can just get, contents kind of coming up there and they grow out of that. But we found that a lot of these babies are swallowing so much air because of how they're feeding with ties in the mouth. When they don't have this organized sucking and swallowing or suck, swallow, breathe patterns, many of these babies become what we call disorganized, or they're chomping and gulping. And if they don't have a good seal, maybe with the lip tie, or just because they have the tongue tie and then they're disorganized in their feeding, we find that a lot of babies swallow a lot of air.
Yeah.
The parents will actually tell you, I hear my baby swallowing the air.
Right. And the air's got to go somewhere.
Yeah, and it goes into the stomach.
Right.
So it goes into the stomach. My, parents will say my baby looks distended, and then a lot of these babies develop secondary reflux symptoms or quote unquote colic. Just a general term. See, it's just colic. Just give them gas, gripe water or whatever, or reflux.
So that air, if it doesn't come up as reflux, then it goes lower, and then it causes air bubbles in the lower intestines, and that causes pain and quote unquote colic. So you did find an association.
So
or a relief of symptoms in the babies you followed for that.
We followed about 1,000 babies, and conservatively speaking, it was about 50%. We think it's up to 80%. Colleagues of ours see maybe about an 80% decrease in reflux symptoms, usually within the first 2 weeks of doing these procedures. And I was able to present it actually at one of the American Academy of Pediatrics meetings. It was accepted, as an abstract and published in a poster there. And that was met, with definite skepticism and, bars and stuff. But there were definitely some pediatricians in the group that were like, yeah, that makes sense. And I think about it. So at least to put it on a radar screen, not all reflux needs to be treated with medications. Maybe just think about it as part of your differential diagnosis, that ties could be connected to that.
Right. And getting back to, how we were discussing before, how little is taught about this, just the fact that that organization let you present about this at their meeting was a big deal, was a big accomplishment.
That was a very big step, and then to publish it, and then, I termed it AIR, which is called aerophagia-induced reflux. So it's a kind of acronym. So that kind of caught on with a lot of people in our field. Actually, it caught on with many pediatricians and GI people in my area who realized, well, because I've actually presented it at some pediatric grand rounds and whatnot. And, you certainly get people who are going to be stuck in their ways and not open to thinking about things that is, because that's not what they were taught.
Right. Well, big pharma is very strong. So if they're learning from textbooks funded by the pharmaceutical agencies, then they're learning about medication, and that's it. And there are so many side effects coming out. I mean, I don't want anybody to be scared. If a baby needs medication, they need medication. 100%. But there are so many babies on medication now, more than ever before. And to me, that's a sign that something's up if we're just medicating babies, because.
And that's one of the things when we were looking at risk versus benefit and the number of babies that we were actually able to wean off. We just don't talk about reduction of the symptoms, but we're getting them off the medications within that time frame. And when we looked at the risk versus the benefit, the risk of doing a frentomy procedure, releasing lip ties, is very low compared to the risks. And those risks have actually been published in the journal Pediatrics. They had a series looking at risks of these, with increased fracture rates of bones.
Right. More allergies.
Because of change and whatnot.
Yeah. So what I see in my practice is a lot of parents will come to me saying, yes, my doctor told me to put him on the medication, and I'll ask if it's helping. And they'll say, it's not even helping, but they're afraid to take them off because the doctor said, the pediatricians are very powerful to young and parents who feel like they don't know enough to make a decision, and they trusting the experts, and the experts are just saying medication. But if we can get them to start saying, or if you're listening now, just ask why, always ask why. Why do you think this is happening, doctor? What else could we do to uncover the reason? And it may not be tongue tie. It could be anything. And this can apply to anything. I always like to ask why, be curious, and realize that as a parent, what's best for your kids better than anybody. If you trust your instinct.
Yeah.
I believe that 100%.
Yeah, that's what I always, tell, even when I talk to young docs or whoever, it's like, you got to listen to the mom. Their gut's telling them something, and their gut's right. Their instincts are there for a reason. Yeah. And if you go home as a mom or a parent and say, that doesn't seem right to me, then it probably
Right.
isn't.
Right. And how many parents have brought their kid to the doctor or to the emergency room saying, I don't know what's wrong, but something's just not right.
Yeah.
And it turns out that, yes, there is something wrong that needs attention, you know? So yeah, parental instincts, especially maternal instincts, are so strong. So, yes. So what's really, cool to me lately is that we can say that the internet is good or bad, and what parents learn on Google and Dr. Google, as it's referred to, can be a little bit overwhelming and sometimes misleading. But
Yeah.
I do feel that lately, when a family comes to me and they have a baby that's having a breastfeeding issue, they've almost always already heard of tongue tie.
Right.
As a possibility. It
Right.
used to be that I used to be like, well, I have to tell you and teach you, and I still do the teaching now, but it used to be like deer in the headlights. What are you saying? I feel that there's more information and there's more good information out now. Yes. And parents are teaching other parents.
Yep.
And professionals who weren't in the field have experiences with their own kids. Yes. And are coming into this field because of it. We've seen that multiple places. Right. I have so many people, so many of the women who took my course, I was asking this question. They started out as something else, like maybe they were an SLP or a chiropractor or even a pediatrician. And now they had a baby and the baby had tongue tie. They went down the rabbit hole of learning about tongue tie, realized they didn't know about it. And now they're learning how to make this their profession and get into the field.
Exactly.
Yeah.
You become tasked with this. Like, I need to educate myself and you want to educate others. It's like, I need to spread this word. And I agree. The number of families, I don't even know if it's the past 5 years that come in so well educated at this point because they did research. It's like, and they went online and got directed to something to figure out. It's like, you don't even have to tell me about it. I've done all my research. I've talked to family, friends who've done this or whatnot. So the awareness definitely is done. They're ready. It's always a double-edged sword with that, but I think it's been more positive.
Right. And as far as results and outcomes,
right?
What do you feel like? Which babies do you feel will do the best?
That's not an easy answer.
I know.
And a lot of that depends on like what you are finding from a functional standpoint. Because, and I still have ones that definitely slip through the cracks, and you just, have no other, team. You have to kind of put a team together quickly for people. But yeah, I don't have a simple answer for that.
All right, that's fair. I think what I'm trying to get at is do you feel that the families who are working with either a lactation consultant or a body worker or an SLP, depending on the age of the baby, are going to do better?
Yes. When I talk about that sort of thing, the babies that have a team and have, been working, with the functional aspect of things, from the oral and the body component, I find do much better than.
Because this is not a quick fix, and you never sell it as I'm going to do this and your baby's going to be fine.
No, I think earlier on we were all thinking that way. This is the silver bullet. You're going to do this and everything's fine. And and there's still parents that get, hung up on that. And and I say, no, this is a piece of the puzzle and this is going to be a process. There are a lot of things at play here. We release this little piece of tissue that's been restricting function, but you still have to work on re-educating those, what we call neuromuscular re-education. You talk to the feeding and the speech therapists like Robin Walsh and Lori Overland, who really talk about neuromuscular re-education. So there's a lot of complex components here that they have to kind of relearn. So it's a process, and that process varies. I have some babies that do beautifully right out of the gate, and some that can take a few weeks to a couple months to get there.
I mean, and there's no predicting that, and that's what makes your job too, but my job very challenging because, a lot of new parents are very overwhelmed. They have, the postpartum period is fraught with anxiety for a lot of people. There's not a lot of support, especially in the last couple of years when different support groups and in-person things have basically been shut down. Hopefully they're opening up again. And there's not as much preparedness for that postpartum period. And it can be very, very anxiety producing. Breastfeeding itself can be a challenge. I'd love to say it's easy, it's natural, it just comes easy, but it's natural, but it doesn't always come easy. And that commitment without the support, and we got parents going back to work right away or juggling other kids, homeschooling and all this stuff that's going on. So it can be, even the families that I work with that have all the resources that I can give them often have a hard time following through with ideal care.
Right.
And we have to make room for that, but it seems to me sometimes that there's kids that are going to do well with little help. And then there's other kids that you can do everything to, and it's going to be a journey.
Right.
And we can't predict that ahead of time.
No, it's not easy. There could be things that we just don't see or know about with their, development and whatnot.
Right.
And I think, the biggest thing like you talked about is the support. I mean, and that might be another question to ask providers, what type of aftercare support long-term.
Yes.
I have patients, every patient gets my cell phone, and I have patients texting me from years ago.
It's great. And you answer. I know you do.
I'll answer like, I can't believe you answered me.
Right.
It's like, well, that's what we're here for. It's not just about doing a procedure and you're on your way.
Right.
So we want to see the outcomes long term.
Right. And that's one of the questions that I have on my list of questions to ask a provider. How will I get in touch with you if I have a problem?
Right. So,
and when do you want to call me? Like what emergencies should I notify you for, and bleeding, fever, things like that. Right. So let's just talk a little bit about that. We didn't talk about that. Yeah. The complication rate is so low.
When I talk about risk versus benefit, when I do a consult with a family and we show them the anatomy, they come in, so the way it would work in my office, let's say you're making a phone call to my office. I'll walk you through the whole workflow or how it works. Is that you'd make the call. My staff is very experienced in kind of talking to you and making sure, the best that they can to make sure you have a team in place. It doesn't always happen, but that we try our best. And, we'll talk to you about coming in, what to expect. And, you come in for the consultation. We typically build in time to do a procedure if it's indicated at the time, because most people are traveling sometimes hours to, or sometimes flying in from other parts. So when we talk about, a consult, the family comes in and I review everything. Why are they there? Who sent them? What's been going on with the baby and their whole history. Birth history is important. We need to know the birth trauma, who else is in part of the team, and then doing an assessment. So I make a diagnosis on anatomy. I'm not really talking about function. I want to know what's going on from a functional standpoint, because it helps me put these pieces of the puzzle together for the family and kind of explain it to them. But then I will identify, there's essentially like 7 points or 7 spots in the mouth that I check, that are kind of classic to have ties or frenulums or tethers. And it's typically the upper lip, the lower lip, the cheeks, what we call buccal, buccal, on the sides, and that could be upper or lower, and then under the tongue. So that's essentially 7 spots, and you kind of have variations of that. You can have multiple little webs throughout the mouth, and multiple ties, or maybe one, but we usually see more than one. And so when I do my assessment, I'll show them what I see or don't see, and then I explain to them. It's like, I see a lip tie. I'll ask them, is the lip flanging out and forming a nice seal over the nipple when they're feeding? I see a tongue tie. I'll ask them, certain questions, and a lot of it is, you go on the checklists and whatnot, but I won't get into the details. But I'll show them the anatomy. And, we take pictures now before of doing anything. So we have it in the records for them. And then we circle back to risk versus benefit. The true risk of releasing these things versus leaving them. especially if there's a functional problem at that point. If they are struggling with function, I don't term these, and a lot of us in our field, parents are always wanting to ask, is it mild? Is it moderate?
Right.
Classify these.
Right.
We don't really classify them that way. I say they're present or not. I jokingly tell people, and I'll say that at lectures, I said, if it's a mild tie, it's like being mildly pregnant to somebody.
Right.
If there's a functional problem,
there's either a restriction or there's not. Right. Yeah.
And if it's impacting function, that's severe to the child or the baby, or it can be severe. So it doesn't matter what it looks like, and then the actual procedure carries very low risk. If done correctly, with an experience.
And with the right tool and with someone who knows how to operate that right tool.
Exactly. So when you look in the literature, we're always talking about, bleeding, infection, injury to adjacent anatomy like nerves, blood vessels, salivary glands. In my own practice, I've not had that. I've had a couple of incidents of some bleeding that were easily taken care of, but I've not had any other issues. So when I talked about issues with the procedure, the biggest thing we really battle, in the real world is quote unquote the reattachment, where things kind of get back together.
Right.
And that's when we start to talk about what we call active wound care or stretching and aftercare.
Getting the wound to heal open, right?
Right. And slowing the healing down. Right. Because these babies want to heal super fast and things can go right back to where they were.
Right. Plus, if they're not using their tongue, if they're not opening their mouth really wide and lifting up the tongue, and the tongue is staying down, then it's going to have the impetus to just come back together under there. So getting the tongue moving is just as important as the stretches, I think.
Yes.
Yeah. So the other thing is, people always ask me if it's painful for the baby. And I know that you respect the fact that a baby can't tell us that there's pain, but we assume that there is pain.
Correct. Yeah. I always assume, and I do a lot of older kids, and I do adults as well. And if you try to laser, and I don't really care what laser you're using, it carries some degree of pain. It hurts. I tried it on myself. So we do our best to alleviate pain with topical numbing gels. And there are, colleagues of mine who don't numb, but I numb. I when I tell parents, I say the babies can't really tell us if it's painful, but they cry, and their crying is, I'll treat that as pain.
Right.
So I try to minimize that as best as I can, knowing that the procedure, in my own hands, just takes a matter of seconds, to do, and it's very short-lived. We still treat that as pain.
And that's one of the reasons I respect you. I mean, I know this is a little bit of a controversial issue and has nothing to do with tongue tie, but there was a few years ago a controversy about not medicating for circumcision in the hospital. We never gave anything for pain for circumcision. And the thought of that now is horrendous. And we had doctors fighting the new protocols of using a numbing gel, which is just crazy. Like, we just assume babies don't feel anything because they can't tell us. Just thinking about that trauma, that's where I got the idea that I would never want even that quick laser procedure to be done without anything for the baby. And then afterwards, in my experience, the babies, because we hear a lot also, the other complication that's not from actually the surgery, but something that can happen is oral aversion, meaning the baby now doesn't want to take anything into their mouth. And I would say when the procedure is done right and the baby is medicated both during and after, I almost never see oral aversion. Like, maybe I'll hear from a mother who's having trouble that very night, that the baby's a little unorganized with getting onto the breast, or it hurts them and they're crying a lot that one night. But if we treat them with certain protocols, I haven't seen oral aversion, except in kids that were not done properly and maybe redone by the same person that made the mistake in the beginning and put through the same protocols. I like to say, if a baby needs to be redone again, don't do the same thing and expect a different result.
Yep.
Right? Always change it up. Think about, well, why did this happen and what can we do? Whether it be more body work or a different type of body work. Maybe they need CST instead of chiropractic, or change it up. Think about pain relief. So do you hear a lot about oral aversion? Because I'm not hearing that.
No, on occasion we'll get cases like that, but then there's usually something else going on as well.
Right.
A lot of times it's not just from the procedure itself, but there's other factors involved. That the baby's having disorganized suckings, or maybe a parent's technique wasn't great at home, or something, or something else was going on. But not.
And babies pick up our anxiety a lot too.
100%.
Which is why I have a whole thing about what to do that night. Low lights and taking a bath with the baby if possible, and just keeping everything calm. Rescue remedy for everyone in the house, keeping everything toned down and calm and quiet and lights low. That's not possible for everybody, because some people are going home to a house of 3 or 4 other kids, right?
Exactly. Right.
But preparation is key and support is key, as always. So, Dr. Siegel, is there anything that I didn't ask you about? Is there anything you'd like parents to know or professionals to know that I haven't asked you yet?
I don't remember what I even spoke about.
So if you were talking,
I think we hit the salient features of this whole thing. I think the biggest thing to do is do your due diligence, when seeking out a team or provider or whatnot, is just to really make sure you're doing your due diligence, whether it's online research or personal referrals or whatnot, just to really make sure, because we see so many of those issues not happening, and I'm seeing the aftermath, and then it's much more difficult to kind of salvage some of these situations.
Exactly. And you don't want to put babies through unnecessary procedures, right?
No. First off, do no harm.
Exactly. Well, as always, it was a pleasure talking to you today. Thank you so much for being on the Tongue Tie Experts podcast. I'm sure we'll be on again together at another point, because there's so much we could talk about. We could talk for hours on different topics, a little deeper, right? But thank you so much for being here today.
Thank you, Lisa. It's always
all right. Bye-bye. Thank you so much for listening to this week's episode of the Tongue Tie Experts podcast. Please subscribe to us on your favorite podcast app. If you enjoy what you hear, we'd love it if you'd rate, review, and share with your friends. Check out the show notes for useful links about the topics we discussed on this week's podcast. Also, you'll find the ways to follow us on social media. Bye-bye. Tongue-tie cases can be confusing, but what if you had a place to ask questions, learn from experts, and connect with professionals who truly understand? That's exactly what you'll get when you join Tongue Tie Experts Insiders. It includes monthly online meetups with me, Lisa Paladino, expert guest speakers sharing the latest research and best practices, a private community of other professionals ready to support you every step of the way. For just $19.99 a month, you'll never have to navigate tongue-tie cases alone again. Join the community today. Your future self and your patients will thank you. Sign up now at tonguetieexperts.net/insiders.